Africa CDC weekly briefing. This platform is set up to facilitate weekly engagement with members of the media to provide updates on key health issues on the continent, particularly the Mpox outbreak in affected EU member states, cholera, Ebola, and other health emergencies across Africa. Today, we have with us Professor Yabom Sekon, the Deputy Incident Manager of the IMST based in the DRC, who will be sharing with us the latest regarding all of these outbreaks that are named and some very important information as it relates to Africa CDC engagements at the level of the UN General Assembly this week. Just before I bring in Prof to begin the section, we want to sincerely apologize that today we don't have the usual translation for you, the French language translation for you, because our colleague is unavailable. We sincerely apologize for that. At this moment, I will turn over to Prof to begin the section. Prof, it's over to you.
Good morning. Good morning, New York, where the UN General Assembly is taking place. Good afternoon, where we are currently in Addis, in Kinshasa, all over the continent, and then good evening for those who are already ahead on the side of Asia. Today is my pleasure to talk with you to bring you up to date on how we respond to the ongoing outbreaks of Mpox, cholera, Ebola, but also to give you some update on what is happening currently in New York, as I mentioned, which will definitely have an impact on how we shape, how we build, how we transform the public health in Africa. So I'll be happy to have it with you. And prior to that, I thank you once again, the journalists, for this 55th press briefing, and you've been following up. And then we appreciate that you are opening it more and more beyond the outbreak that we are responding. And of course, it's always an opportunity for me to thank really all the colleagues that are in the field, from the IMST, from the member state that are fighting tirelessly, responding to those different outbreaks that we are going to present today, but others. We have measles, we have quite a number of others that we need to appreciate their commitment to that. So Nick, over to you for the presentation. Thank you. So as I mentioned, the UN General Assembly is taking place currently in the United States, and this is an opportunity to broaden the spectrum and then to ensure that all the different aspects of our world, our wellness, are being discussed. And as you remember, Africa CDC is critical on this triptych, which include the political, the strategic, and the operational. So being at the UN General Assembly is an opportunity for us to be at the highest level of the continent, but also the partners that are engaged in transforming what we call the new public health orders. Next slide. So our Director General, Dr. John Kaseya, and quite a number of our colleagues are currently there, present in different discussion, different side events. This one is really emphasizing the role that we are doing on empowering the work that the community healthcare, the health workers are doing. Because community health is really the foundation of primary healthcare. This is also the place where we want the response to outbreak through the surveillance, to the risk communication and community engagement happen. So we have this bold target of 2 million community healthcare workers by 2030, and we are halfway. We already have 1 million in the continent. So this is an opportunity that we have to discuss how different partners can actually support. And this requires, as a next step, the political will, the sustainable domestic financing recognition of community health workers, which is essential. And that's the only way that together we can build a resilient system that deliver health for every community. Whatever you do for me, without me, is against me. That's why critically, we put the community really at the center of the way we transform public health in the continent. Next slide. beyond the usual outbreaks and epidemics that we are addressing, it's also an opportunity, you will see, to look at the non-communicable diseases by true partnership. This one is a partnership with Novo Nordisk Foundation, which I've launched more than 2.5 million initiatives to really boost the surveillance in 10 African Union members. And again, we will go back to the same issue of community healthcare workers who will be there in the front to ensure that during the next 2 years, they will be in the community. They will be strengthened on data collection, data analysis, because we need those data as evidence to actually purport the adequate response to those NCDs. So this partnership is really a milestone for Africa health sovereignty and the new public health orders. Next slide. Still in the non-communicable disease, sickle cell disease. You know, sickle cell is a disease that is majoritarily found in the continent. So if you've been following us and following the partnership that we've made through an MOU with Texas Children's Hospital, now we are moving further. Why? Because every hour, 45 children in Africa are born with sickle cell disease, and too many won't reach their 5th birthday. This means that there is a huge gap on our community to understand what are the risks, to know actually what are the status, whether they are carriers, so that when they will get married, they need to have that proper understanding and therefore decide whether to continue or not, but at least knowing what are the challenges of having children with sickle cell disease. Now, in terms of action, we as Africa CDC and the AU member state and our partners are integrating sickle cell disease into primary health care and expanding access to affordable medicine so no children is left behind. So that will help us to build a healthier and a stronger Africa. So that was the key message during the launch of this partnership that is being made by Africa CDC, Ghana, in collaboration with Texas Children's Hospital. Next slide. At the highest level of our continent, we have the head of state, of African Union, which is chaired by the president of Angola. So those leaders sat together with Africa CDC and other partners to really reconfirm Africa CDC as the continent's public health agency. And this is not only words, this is really a commitment to working hand in hand with AU member states and also the partners to really strengthen the preparedness, to promote health sovereignty, and to safeguard the continent's health security. So to achieve that, they really call for stronger solidarity, sustainable financing. You remember the innovative funding, the domestic funding, and the blended financing. Those are the key pillars that Africa CDC is pushing as the financing is being concerned. And this is to move toward Africa health sovereignty and to protect our population from the current disease, Mpox, Ebola, cholera, but also the future threat that our continent will be exposed, especially as we move in an era which is affected by the climate change. Next slide. Now, coming back to the state of the public health event, as you can see, we still have the same top 5: Mpox, cholera, measles, dengue, and of course, Lassa fever. And you can see that the number of events, whether moderate or high risk, keep on increasing at a higher rate as what we did see last year in 2024. So as cholera is concerned, and then we come back to that, we can see that we are almost at 250,000 cases, while the number of confirmed cases is around 7,637, and the number of deaths is now around 5,795. So the number of countries affected, definitely Mpox remained the highest, but you can see that the measles also with 20 countries affected is also one of the key and the big challenges. We have dengue, we have Lassa fever, who are also in the continent, and then we are happy to remind the engagement in West Africa around Lassa fever in terms of research, in terms of vaccine, in terms of diagnostic, which is, of course, very highly supported by Africa CDC. Next slide. Now, as we are currently in DRC, we still face this outbreak of Ebola virus diseases. As we do speak, 48 confirmed case has been detected, 27 deaths, which gave a case fatality rate of 56%. And then we have one health zone which is affected. This is the zone de santé of Boulapé. So now, what is important to highlight in this response is the contact tracing. The contact tracing is what ensures us that all the people who have been in contact of one case, they must be identified, they must be followed for 21 days. And as you can see, the case to contact ratio, the number of contact per one case is 1 out of 25. Which is quite encouraging. The threshold that we are looking usually is 1 for 20. So being beyond that is a good sign that the surveillance is actually in place and ensuring that we kind of know all those contacts. Now, the second step is the contact followed up. You can see that 97% of the contact have been followed up, which is quite great, though one which is not followed is always a risk, but at least the team on the ground keep on following that and ensuring that they kind of they reach the 100%. The number of contacts that have completed the 21 days follow-up are now 60. The attack rate is 3%, and then you can see the bed occupancy is more than 117%, though you remember, we have increased the bed capacity from 21 to 34 beds. So we still need some improvement, and the partner currently in the field are working hard and ensure that we can increase those capacity for bed. Now, in terms of vaccination, also more than 2,000 people have been vaccinated with around 300 of frontline workers, 610 contacts. And then on stock of vaccine in that site, we have more than 2,000, knowing that at the country level, the country has received more than around 45,000 doses of vaccine. So that is quite reassuring. And then the team are quite busy on doing the micro planification and seeing how in the next few days, they will be able to extend to accelerate the vaccination and ensure that all the population that is at risk, the contact, the frontline workers, and so on, are being vaccinated. Next slide. Now, we wanted to present this table to you to show how we are progressing. We take those outbreaks as opportunities. This is an opportunity to digitalize the surveillance. And this is a dashboard that shows you the number of people vaccinated. That now in this one, as per yesterday, there were 1,908. You have the distribution per age, and those data are provided in real time. And that is critical because it gives us an idea of whether we are achieving our target, an idea of the population that received the vaccine, and that can guide the micro planification so that we keep on moving, but based on data. So this, what I'm presenting, is for the vaccination. And next week, we'll be able to show you what the same dashboard which is used for the surveillance, where you have the alert, the investigation, the people who are in treatment, the lab result. This is for us something that we started during the Mpox, and we want to ensure that every time that we have one outbreak, we take advantage on improving the way we do the surveillance, the way we respond, and therefore the way we prepare to the upcoming threat or public health event. Next slide. Now, going to Mpox, we keep on seeing the declining in the number of cases, confirmed cases, and number of suspected cases as well, which is remain encouraging, but we need to really push toward the transition. And that was the agreement of the interaction review and the transition roadmap workshop that we had last week in Addis Ababa. So because at some point, as you will see in the presentation, there are some countries where you can see that it is quite stagnant. So at which stage, we decide that we are moving from the outbreak mode to the endemic mode. You know, we have what we call those protracted outbreak, which goes beyond the usual 6 months of an outbreak. So we need to adjust how we respond to them. And then Mpox is a very good case. So, but good, you can see the testing coverage has been increased, which means that we control what is happening. When we mention that there is a decrease, we are quite confident on the fact that most of the suspected cases are being tested, and therefore we are confident on that. Next slide. Going to DSA, who is still the country with the highest number of cases. You can see that 31,000 confirmed cases all together, with almost 2,000 deaths, with a case fatality ratio of 1.5% among the suspected cases. But among the confirmed cases, we are around 0.41%, which is also highlighting that the case management has been quite appropriate. A lot of effort has been put in place in terms of surveillance, in terms of case management, as I mentioned, but we still have the North Kivu, the South Kivu, and even Kinshasa that account for 63% of the number of cases. So you can see that those provinces, especially the South and the North Kivu, are still contributing significantly, while the access is still not as smooth as we want it to be. Now, what also is interesting in Kinshasa, and as we've seen in Kampala, but also in Freetown, is that we have an important proportion of our patients who are HIV positive. Actually, in DRC, we also see, on top of HIV, we also see the confection with syphilis. And this, again, push us to the integration of the Mpox response within the other system, so that we don't reinvent the wheel, especially in the time where the resources are limited, but moving forward more efficiency, having all those programs, talking to each other, and ensure that we see the patient at one, and then we can provide the testing, systematic testing of HIV for all the patients who are positive for Mpox. Those are some of the initiatives that different countries have been put in place. Next slide. In Sierra Leone as well, we keep on seeing the decrease. If you look at the last 3 to 6 weeks, there is a decrease, though from last week to this week, we moved from 21 positive to 26. Still, we've not been having there for some weeks now, which is quite encouraging. You'll recall that we were highlighting that the case fatality ratio was the key challenge for Sierra Leone. So we really commend the country for the great job that has been done on that side, as well as the other side, which are the surveillance and the vaccination. So we see that sharp decline in the case, driven by the ongoing active search, and of course the sensitization, which is happening door to door. It's also important to see how they have translate some key messages to sensitize the community. There's, for example, one radio where sex workers is insisting that the customer has to be screened before going in any practices. So by having those kind of measures that are very contextualized, it's also a key driver to change the habit, to change the behavior, and therefore limit the spread of the disease. But still, in the Western area, urban, and the Western area, rural, together still account for 3/4 of the number of cases. A lot of work has been done in the lab with the sequencing, where more than 10% of the confirmed cases are sequenced, which is quite reassuring on the circulation of the clade 2B, and knowing that the actual target was 5%. Next slide. For Liberia, which is a country that will have next week the intra-action review, we have been engaging the country this morning to understand a bit more the driver of this increase that is continuing. And definitely they highlight it, the need to strengthen the surveillance. You can see the test positivity rate is improving from 90% to 66%, which means that they are a bit more in the community so that they can catch the patient at the early stage. And this is something that will be discussed next week to see how we can accelerate that process so that we can decrease test positivity to around 30%. That will be a bit more reassuring. They also highlight the challenge that most of the patients are managed at home because the health facility were not fully appropriated. So now they are starting to increase. They have around 100 people who are taken care in the health facility, while 68 are taken care at home and vice versa. So it's critical to support, especially in MODERATOR, where 68% of the total confirmed case, they contribute to that amount across all the counties. Next slide. In Guinea, where we have been having confirmed 965 confirmed cases, with one death among the suspected case and one death among the confirmed case, giving a case fatality ratio of 0.1%. We see a decline this week, actually by 58%, which is quite encouraging, but it's also require more vigilance. The good news is that, as you can see, the indicators are quite good. The testing coverage, the testing rate, the test positivity around 30%, which is quite encouraging. Now, what is critical is really to focus on those key hotspots: Conakry, Kindia, Farana, Kankan, Bokeh, and Mamou, and also strengthen the case management. As you can see, 80% of the patients that are hospitalized are severe. What it means is also that people come to hospital in an advanced case. Now, the question that we'll ask is whether those people are also having comorbidity, and what is the best way to strengthen the surveillance. So we have some colleagues currently in Guinea who will help us to support, as well as I will come back later to the issue of vaccination that the country will also benefit. Next slide. In Kenya also, which is another country where we are quite vigilant, we can see the increase in the number of confirmed cases moving from 2023 to 52 as compared to last week. And then the hotspot are Mombasa, Busia, and Nakuru. So it is critical. They've managed to deploy 10,700 doses of vaccine, fully achieved during the campaign, 100% of the target. Now they're expecting more doses of vaccine so that they can really also include the new area like Nairobi, and ensure that the key population, the truck driver, the sex workers, and others, actually, not to stigmatize, are really considered for the vaccination. Next slide. Continuing on the side of vaccination, we are glad to see that as per today, we have 15 countries where 4,700,000 doses have been delivered, including MVBN, but also the 3 million doses of LC16 that were shipped to DRC by Japan. So 18 countries have granted the approval, though some other countries, 3 countries, are actually got the approval from the NITAC, the body that advised the Ministry of Health on the use of fractional dose. So that is also encouraging on the innovation of our mantra, how to do more with less. So it's encouraging to see that Sierra Leone, Zambia, and Uganda will be leading that innovation. So 1,012,000 doses has been administered to 1 million people, which included MVBN, and 39,000 in DRC with LC16. Next slide. Now we move from a time, if you remember, some few months ago, we were having 0 dose of vaccine. So now we do speak now, 485,000 doses are available. Available, yes, but it's important to highlight that 266,000 are still at the manufacturer, and they require some fund to be bought by UNICEF. So they are there in case we need, in case we have the fund, they can be made available. On the other side, we have 200,000 doses that were donated either by the manufacturer MVABN or by UNICEF, and then some countries are being considered. As we do look now, we have Zambia, which Zambia, Guinea, Ghana, who has been receiving some doses of vaccine for a total of 63,000 doses of vaccine altogether. And then we have some pending shipment. Liberia will receive 42,000 doses this week, as well as Uganda will be receiving 42,000 doses of vaccine, which means that we really move from the time where we were having only 20,000 doses for the continent, and now we are almost getting to 5 million doses of vaccine. Though we are not yet there, because if we really want to consider the epidemic, but also the endemic, we'll definitely need much more doses of vaccine so that we can really increase the immunization of Mpox, especially in endemic countries. Next slide. From Mpox to cholera, you can see the number of cases of cholera, what you can easily see in 2025. We are still in September, and we already have 3,000 more cases than what we had last year. And in terms of death, we have 1,000 deaths more than what we have for the entire year 2024. The member states so far affected are 23, while for the entire year 2024, they were 20. So this is where we stand, and this is why we are really pushing for the implementation of this continental cholera emergency preparedness and response plan for the continent 1.0. And as I highlighted earlier, what is happening at the UN General Assembly on those side events, the commitment of our leaders is also to support the implementation of this plan with the partners. So we have, for example, Gavi that has pledged to support the 10 million doses of vaccine that has been highlighted in the plan. We also have UNICEF that are also committed to support quite a number of pillars. So this is a work in progress to ensure that we have all the resources, the financial resource, the technical resource that will allow us to implement this plan and then to ensure that we have a coordination within the continent. This is the legacy of the Mpox response using the IMST as the pillar. Next slide. Now, going back to specifically to country, we can see that Chad is definitely the top country, the country of concern as we do speak now, not because it has the highest number of cases, but because when we see the trend that is going on, it is quite challenging. So yesterday we had an engagement with the country, as we do as IMST. We talk with the country to ensure that we understand properly the needs, and therefore we can look amongst the different partners how we can support them. We also have Congo Republic and Burundi, which was also highlighting this morning that the situation is getting very challenging, and they need some support on how they can respond to this outbreak. Next slide. Now, as you can see in chart, from last week, we can see some improvement in the reduction of the number of cases by 33%, but also the number of deaths. So the highlight, as was mentioned during the different conversation, is that the current hotspot are still Wadai with the 6 health district and Sila with 1 health district. But they are seeing that while it was starting from 1 refugee camp, the refugee and the returnees, now we have more health zones that are getting exposed. So once again, it started in mid-July at the Dugi refugee camp, and now we see more health zones that are affected. So in terms of intervention, it means that we need to support them in the surveillance to ensure that we know where the case and the death are happening so that we can prevent, and also that will help us to know where to support the cholera treatment center, but also the rehabilitation spots. So this is the critical need that they have currently. And also what we are pushing is to see how we can have a political support so that at the highest levels, we can really provide them the support that they need. Next slide. Next slide. Still in Chad, there is a strong correlation between the flooding and the cholera in many ways, because as you can see, this affects the access to water. That is one. Secondly, it also affects how our colleagues in the field can access the place where the patient are located. So this is an opportunity to highlight, there was some question last week or 2 weeks ago on the impact of climate change. So it impacts in many ways, and this includes the flooding, which impact the way the spread of the disease is occur, but also the frequency. We are taking the example of Chad, but as you can see later, it will be the same story with Sudan and South Sudan. Next slide. So as I mentioned, in South Sudan, we gladly see the decrease in the number of cases. The deaths are stabilizing, but again, we still have a persistent transmission in Juba, in Bor South, and Tereka, and part of the Upper Nile because of the poor access to water, sanitation, and drainage. And once again, you can see that there is a link with the flooding, which increase the contamination risk, but also decrease the capacity for the team in the ground to actually be able to access the population. So in moving forward, so that we can really end this outbreak, definitely the scale-up of WASH remain an emergency package, intensify the communication in some place as we heard today. Some people still believe that the cholera is not due to poor access to water, but is due to witchcraft. So it's critical also to support those countries and providing the right information to the population so that they can apply the good and the right behavior. Next slide. Now in DRC, where we are seeing a decrease in the number of cases, though the death has increased as compared to last week. And once again, we go back to the same places, the South Kivu, which account for 60% of the total new admission this week, with an extension of the epidemic from the Nundo Health Zone to Uvira Health Zone. And then we have some colleagues of IMST from UNICEF who are currently going to Uvira to see how they can also support the cholera, but also the Mpox and other outbreaks in an environment that is not very friendly for the humanitarian to operate. So we have this increased number of cases in South Kivu, I already mentioned, but also in North Kivu, Tanganyika, and Chopo. Next slide. So in terms of forecast, just to highlight that as Africa CDC, we have the climate change and health strategic framework, and then we monitor, we really follow the climatic condition, because that is a critical tool for us to support the country in terms of preparedness, but also in terms of response. So as you can see, for heavy rainfall and flooding, we can see that continue moderate to locally heavy rainfall along the Gulf of Guinea, which heighten the risk for flooding in local area and sub-region. I mentioned the issue of Chad, but also even in DRC, where there are some preparedness action happening. Next slide. So we are going toward the end. So just to say that the Ebola situation is still present with the great support that is implemented in terms of contact tracing, digitalization of surveillance, the targeted vaccination, but also the preparedness that is happening in Angola, which is neighboring countries. So we will keep on strengthening the surveillance, the cross-border surveillance, as mentioned, but also, and quite critical, the scale-up of the community engagement. Next slide. For Mpox, we have the high-burden country where we gladly continue to see the decrease. We have other countries, Guinea, Liberia, Ghana, Mozambique, Kenya, and Nigeria, who are seeing some increase. Next week, the interaction review is happening in Liberia, and the team will be supporting to ensure that they adjust their response, consider the results that are available. But the critical point, the surveillance, the vaccination, the cross-border coordination, so that we can prevent the resurgence. We have 2,000 doses of vaccine that are available, though the challenge of having the operation fund still remain. Next slide. For cholera, we report a decline of 33% over the past 6 weeks, but we have a country like Chad, South Sudan, and Sudan, which are also affected by the flooding, which also is one of the drivers of the outbreak. We've seen some decrease significant in quite a number of countries, and now it's critical to follow up the launch of the mobilization resource that happened at Wunga with the engagement of partners to ensure that the Continental Plan 1.0 is fully funded. Next slide. So with that, I will thank you all, and then I will be happy to move toward the session of question and answer.
Thank you, Prof, for the very succinct and informative briefing section. At the moment, we will transition to our question and answer section where we take questions from the journalists, and Prof and the team and members of the IMST who are available will respond to those questions. So our question procedure comes with those of you who raise your hand on the Zoom platform, you will be recognized. We are also picking questions from our the Q&A section as well as we go along. And those of you who have already written your questions during registration, we are also going to pick that as well. So we're starting off with the issue of Ebola where we just ended. And our first question comes from journalist Lucia Blanco, who writes for the Spanish news agency. Lucia says, can you clarify the disparity in the number of cases and deaths because of Ebola depending on the sources? And her second question adds, can you also comment on the situation on the ground? Is there a lack of resources as has been reported? So those are three-part questions. I'll give that to you first, Prof, to answer. Then we'll move on to the second one. Over to you.
Thank you so much, Lucilla, for the great question. So for the disparities on the number of deaths and cases by sources, so it is true that when there is an outbreak that starts, you have quite a number of actors in the ground, sometimes using different tools. And that's why we want to push the digitalization of the surveillance using one tool for everyone. Once you have many different tools, many case definition, therefore you come out with different number. They will talk about the suspected case, they will talk about the confirmed case, they will talk about, So what we are pushing, and that goes back to the strong coordination that the Ministry of Health is putting with the different partners, is to ensure that we have only one way of describing. So this one is highlighting the confirmed case, which as per today was 47. We confirmed the death among the confirmed case, which was 28 for a ratio of 56%. And therefore, we no longer have suspected cases because the suspected cases are those who exist before they are being tested. But now that we have the testing capacity available, then we should not be having those ones. And the next step is to ensure that all those data are collected in a real time using the DHES2 tracker, which I've shown to you for the vaccination. Once that is fully implemented, which is happening currently, then we'll be all having the same dashboard as we did for Mpox. So the situation on the ground versus the resource, an outbreak of Ebola requires a lot of resources. The resources are not as much as we need, at least as we do speak, because the colleagues in the field are really pushing. But the next step that we really want to ensure is that we have the deployment of community healthcare workers within all the health zones that are currently hotspot, but also around, so that we don't run after the outbreak, but really in front. And this requires a significant amount of funds that has been mobilized. And then we believe that in the next few days, we'll be having the opportunity to have those one on board. So we need to keep on mobilizing resources for some of those activities to happen. Thank you.
Thank you, Prof. So we've got some hands raised, but let's deal with two more questions from the chat, and then we'll come to the colleagues who have already raised their hands. So our next question comes from Edith Mutenya. She writes for China Daily, a senior reporter. Edith says, how are the countries bordering DRC or DR Congo strengthening preparedness for possible Ebola response? That's Edith's question. And then let's take a second one from our colleague, Tanekat Mora, journalist from the Center for Innovation in Zimbabwe. And Tanekat says, how is the progress of Mpox cases in Africa compared to international cases following the lifting of the emergency status by the WHO? So one from Edith there on Ebola and the other one from Tanekat on Mpox. Over to you, Prof.
Yes, thank you so much. Those are very critical questions. The first one for Edith is how the neighboring country, first of all, to emphasize that the country that is the nearest to that zone is Angola, because the mobility of the population might allow them to move to that country. So before talking about how the preparedness is happening in Angola, it's critical to say that even within the health zone and at the borders, we have the screening at the point of entry. As per this early week, more than 3,000 people have been screened. So to be checked to ensure that they don't have any sign and symptom of Ebola. None of them were eligible. So none of them were having any sign or symptom. That's the first thing to reassure that the first surveillance across border is happening in the side of DRC. Now, in the side of Angola, the preparedness is happening through the IMST and the different partners, because when it's go beyond one country, that's when the coordination at the regional, at the global level really happens. So we have the colleagues from UNICEF, from US CDC, and also Africa CDC that are engaging the country on ensuring they had all what is in place in terms of laboratory to ensure that the reagents are there. We know that the facility are present, but the refreshment, the reagent, as I mentioned, but also that some training are being put in place so that we can start with some communication and risk engagement, which is really the strength of UNICEF, to avoid that in the country you start having some stigmatization, which can actually go in the wrong side. So we have all those partners in the ground working together with the Ministry of Health, ensure that the preparedness is being implemented. So the question for Tamakwe, I think from Zimbabwe, and asking, following the lift of fakes, how the projection of case have been happening. So first of all, the lift, and once again, of the fakes happened early September, while the fakes on the side of Africa CDC has continued, and within WHO, the African region, they've maintained the grade 3. The grade 3 means that all the resources are still maintained to respond to this outbreak. So what we can see is that the situation continue as we present. We can see that the decrease in most of the high burden countries, but increase in some others, which highlighted that the situation is definitely not resolved. And that's why the different experts sat together and see how we can support the country as we move in that transition. Definitely, our hope actually is that we also lift the facts in the next 3 months or so, because they will have control of in all the country, because the country will be now ready to integrate the Mpox into the surveillance, into the national health system. So that is really critical. That is the aim, but we are not yet there.
Very much, Prof. Let's now go to our colleagues who have raised their hands to take questions from the live section. We have 3 hands. We have Kumbalai from the Gambia Daily, followed by Hafiz Hanafi. He's a journalist based in Nigeria. And then we have Rachel Abuja, who is also from Nigeria News Agency. So in that order, let's start with Kumba, then Hanafiz before Rachel. Kumba, over to you.
Thank you for giving me the opportunity. Thank you for that presentation. I have 3 questions to ask. First, to start with regards to WHO just adopted pandemic agreement. We will want to know, and the pandemic emphasizes equity. I would like to know, how does Africa CDC see this shaping Africa's role in global health governance? That's the first one. The second one is, many African countries struggle with vaccine inequity during COVID-19. What guarantees does the pandemic agreement provide that this wouldn't happen again? And how is Africa CDC positioning itself to hold global partners accountable? That's the second one. The third one is data sharing is a major pillar of the agreement. How will Africa CDC ensure Africa benefits from global pathogen sharing mechanism without repeating past injustices where African samples were used, but benefits like vaccine never returned to the continent? Thank you.
So I will appeal to our colleagues. Those are three loaded questions. So we'll have Prof to take those three. Hafiz and Rachel, let's allow the Prof to answer the questions, the three questions, then we'll come to you next. Thank you. Over to you, Prof.
Yes, thank you. Thank you. Those are critical questions. 3 weeks ago, Africa CDC held some experts that came out all together to Addis Ababa at the headquarters to ensure that Africa speaks as one voice, so that we convey the Minister of Health and to discuss this specific part, which is the PAPS and the pandemic agreement specifically. So Africa CDC role is really the convening power, bringing all the Minister of Health at the political level, also bringing the expert to highlight what you've mentioned, how to ensure that in terms of the legal blindness, to ensure that there is a clear pathway on how the population that have contributed through the specimen, through the clinical trial, to all those activities are rewarded or considered in the way the agreement is being implemented. But all those is around the continental sovereignty. So the Africa CDC really links the past position to a broader continental agenda, which is really to strengthen that health sovereignty, which also include the issue of local manufacturing. You are talking about the issue of inequity that we've seen with the COVID vaccine, but this had happened, and even now with the Mpox vaccine, because we are not producing those vaccines. So it's only by ensuring that this local manufacturing is being implemented that we will have the capacity to ensure that we have the vaccine and all the medical countermeasure being available for our population. So the last point was on the data sharing, if I get it well. So Africa CDC is also through taking advantage, let's say, of this outbreak of Mpox to ensure that we have a common way of collecting our data in terms of emergency through the DHIS2 tracker, so that at some point we have all the data from all the country all together managed by African. Note that some of those data will be out of the continent, because when they're out of the continent at some point, we don't manage them. And then we don't manage them, they contribute, as you rightly mentioned, and I can hear, they definitely contribute on producing some diagnostics, some vaccine, some therapeutics, and when those ones are available, we cannot use. I will just bring us back a while ago. There was a study that was performed, I think it was in Nigeria, on the diagnostic for Lassa fever. So the population contribute, the result for this test was really amazing, and therefore the tests were actually validated and produced. Now, 1 year later, when there was a big outbreak in the same region, the population were not avail the test they've contributed for the research. So this is really where we are coming from. And this, all the agreement, all the work that Africa CDC is doing with all the partners and the Ministry of Health is to ensure that this not happen again. Over.
Thank you, Prof. We have 10 minutes to go. We will appeal to Prof based on the number of questions that we have. We can extend your time by an extra 10 minutes so that we're able to cater for most of the questions as our colleagues have made efforts to join. So let's now go to Rachel and then Hafiz.
Thank you very much. I don't know if you can hear me.
Yes, we can hear you, Rachel. Go ahead.
Prof, thank you so very much. Last week we had an incident in Nigeria where we would like to describe that as a false alarm for Ebola. and we found out that the patient came in from Rwanda. My question is this: are there no communication between the continent where a physician will not allow a patient to travel all by himself to his home country without informing let's say, the incident manager of that country first? Is there a way we can have this cross collaboration where the incident managers can be talking to themselves? Because thank God the patient was negative, but let's assume that he's positive to Ebola or Marburg or dengue fever. So the physician allowed him. He passed the immigration. He flew with passengers, over 300 passengers. He got himself to the immigration in Nigeria. He took Uber home. He found himself in a hospital where he was admitted before he narrated his story. So I don't know if there's anything we can do on the continent to ensure that we have this cross-collaboration where we talk to each other to ensure that we don't have such incidents next time. Thank you, and over.
Thank you, Rachel. Prof, let's add the second question from Hafiz. Hafiz, if you are still questioning, otherwise we notice that you've dropped your hands.
Oh, okay.
Go ahead.
All right, thank you. Thank you, Prof, for the briefing. Okay, I'm going to make my question very brief. My question is about cholera outbreaks, which many African countries, including Nigeria, record almost seasonally, particularly during rainy season, which we are now. I would like to know what the African CDC is doing regionally in terms of intervention to ensure that the number of outbreaks and the number of deaths recorded during this period is reduced drastically. Perhaps in terms of maybe vaccine, OCV, or in terms of wash interventions. I would like to know what the African CDC is doing in this regard. Thank you, and over.
I can take them?
Yes, Prof, you can take those two.
Okay, thank you. Thank you so much, Rachel and Hafiz. I will start by Rachel, of course, on the story that you're highlighting in Nigeria. First of all, remember that it's not the first time that Nigeria has that first one alert, but I even recall a few years ago, there was a case that was very well managed by the NCDC of Nigeria of Ebola, I think maybe 5 to 6 years ago, where they really managed to control and then to ensure that, to isolate and to ensure that all was properly done. So just to highlight that the country itself has some very good capacity on the responding. Now, the issue that you highlight goes back to the issue of cross-border data sharing mechanism, which is definitely a work in progress. You know how a continent has different regions where you have different entities, the EAC, the ECOWAS, IGAD, SADC, which communicate within themselves. So now, you mentioned from Rwanda to Nigeria, now we are already moving between different regions. That's why at the level of Africa CDC, we are really pushing to some innovative action. During the COVID, we were pushing to have an app where every traveler will fill some information and the information can circulate within the continent. So though this one has not been continuing, it's not what you are mentioning, it's also an opportunity for us. And in 3 weeks from now, there will be the CFIA conference in Durban and the digital track where I'm pretty well involved. We also have some of those innovations to see how we can strengthen the cross-border surveillance and also the surveillance at the entry point. There were some opportunities of using the AI at the airport to ensure that we properly screen some of the people who are traveling, because, you know, screen thousands of travelers, it's not something simple. We may relate that study that as if it's quite simple, but when you have 10,000 people traveling, sometimes the capacity to screen all of them is not there. Therefore, we need to be more efficient. But just to highlight that there is a work in progress, and then we believe that in the next week we'll have some outcome on some of the innovation in the continent to address this issue. Now, for the cholera, the question of AFIS is what Africa CDC is doing. I think I won't mention what Africa CDC is doing. I will mention what the IMST is doing. You know, the IMST is this platform. This is co-led by Africa CDC and WHO with more than 28 partners. Why? Because we want to act at different level. We've done that for Mpox, and that's why the head of state have decided now, please use the same model for cholera. And using the same model means that we act at three levels. At the political level, so that we have the head of state, as I mentioned early this week in New York, they start the mobilization of funds for the cholera plan. And that plan ensures that 10 million of those of vaccine has to be made available within the next 6 months. Also ensure that we have the resources to implement cholera treatment center, more than 300 of them in the most affected country, but also the rehydration site. So all those actions are within the plan, and the resources are mobilized at the political level. Now, at the strategic level, where we have the IMST and so on, we ensure equity. Now, we have seen in the presentation that Chad is really a key challenge. We've seen that Congo as well. So as we do speak now, we have a team in Congo to strengthen the country on how they can implement community-based surveillance so that they can track all the patients where they are and ensure that the action of access to wash, the proper water is also being implemented. So for Chad as well, we discuss with the country, and then we ensure that we provide the most efficient way, because the way we were working before is each partner will do its own thing. Now, being all together, we know that we work with UNICEF. They are quite strong on risk communication and community engagement. We have WHO, US CDC, who will support the surveillance. We have the multi-sectorial approach, where we need the Minister of Finance, the Minister of Plan to provide the infrastructure so that water is being made available. And lastly, I show you the impact of flooding. So we also need to consider. So just to say that at those three different levels, political, strategic, and operational level, we are working through the plan. And the aim of this plan is that before the next 6 months, we reduce the burden of cholera in those countries by 90%. Thank you.
Prof. We are now into the last 10 minutes, so we're going to take some quick questions from our chat. Our colleague Jonathan Lambert from the NPRO asks, have US aid cuts harm or slow down the Ebola response in the DRC? He's asking about slowing or any harm caused by US aid cuts to the Ebola situation. Let's take a second one, then we give you the time to respond. Kate Lambert, our regular from Guardian, also asks, where or who are you hoping the operational funding for vaccine will come from? So she takes us to the issue of vaccine, and she's asking where or who will the IMST get the operational funding for vaccine. Let's take those two, and then we go for our last two sections of question. Over to you, Prof.
Thank you so much. Sorry, I didn't get the name of the colleagues from The Guardian. Like, I was asking the name of.
Okay, the colleague from The Guardian is Kat Lai. She's a regular on the briefing. Yeah. Okay,
thank you.
Kat Lai, yeah.
Okay, so Lambert from NPR. So the question on the impact of the USG fund on Ebola is quite valid. But the real answer is that we have a very strong commitment and engagement of US CDC currently on the response to Ebola in the country. I show you the critical need of surveillance, contact tracing, data harmonization, digitalization. So together with Africa CDC, they are quite on board on pushing those activities. This is in DRC. Next week, we are also joined to organize a team visit in the field that will be together with WHO, US CDC, and others. So the presence is quite there. Not only in DRC, in Angola also, I mentioned that there are some preparedness activity that will be happening with the support of US CDC. So I will say that the present is there, but again, I mentioned that the resources needed are important. They are needed. Therefore, more resource will help to be even more efficient on the way we respond. Now for the question from Carlisle from The Guardian, where will the operational fund will be coming from for the vaccination? This is a very good question because I've highlighted that we have 200,000 doses of vaccine, or actually 200,012 doses of vaccine that has been mobilized by the manufacturer and Bavarian Nordics and also by UNICEF. And those doses are coming without operational cost. Maybe for others, it's important to appreciate that having the vaccine in country is one thing. Now, having the vaccine reaching the last mile, reaching the people that need those vaccine require a significant amount of fund. So far, the main supplier provider of those funds has been Gavi. Those are the ones that has been really supporting. So now the conversation is ensuring that we increase the partners who can support the dose. But also, we need to take the example of Uganda. Uganda has highlighted that even without external operational fund, they can mobilize at the national level, the domestic funding that we've been talking about, and they will be able to absorb 100,000 doses through the different partners, public, private partners that will help to support. In DRC, at some point, there was a mining company that were also supporting the Ministry of Health on deploying some vaccination in some area. So this is now the time, really, where we need to rethink and be more efficient on how we can find the fund to get the vaccine reaching the target. So practically, we've been having Gavi. Now we are extending and finding domestic funding. Uganda will be able to absorb half of the dose locally. And then now we are mobilizing some funding so that we can actually allow other countries to receive the vaccine and the funds that are required for the dose to actually be distributed.
Thank you, Prof. We will just take our last two questions for this section, and that will be it for today. So the first one says, is there any updated available data on Mpox in Ethiopia? That's a straightforward question from Saron Shanafi. And the second question for this batch to end our section says, is there any information about the 5 patients reported to have died following treatment with Ibanga in the DRC? So you want me to repeat that question?
No, I
Okay.
got the question on the use of Ibanga in DRC for
yes.
Ebola.
And then the first question I asked was any new available data on Mpox in Ethiopia? Those are our last 2 questions for today's section. Over to you.
Okay, thank you. Thank you so much for the question. In Ethiopia, we're still at 18 confirmed cases amongst the 7 regions, and then with 1 death. And then you remember that the death was a baby at the time, and that has been real trauma. When we were discussing with the Minister of Health at the time, you can feel that she was still challenged by the fact that they were not able to avoid that. So this is what is happening, but more importantly is the way forward. We are working together with the countries on supporting them of having their vaccination plan. As we have some few doses of vaccine available, it will be critical, especially around in those area of Moyale, Jima, Oromia, and Sidama, that they can have some vaccine in case there are cases around that they can be able to support that part. That is for Ethiopia. Now, the second question is the use of Ibanga, which is actually the MAB 114. This it's an interesting in heritage of research. It was discovered by the team of Professor Muyembe, which is also the one that has discovered Ebola a while ago with Peter Piot. And then this time they were having in country 100 treatment for 100 people to be used, and that was brought to the field by Africa CDC to ensure that it is being used. So this is the actual treatment that is being used in center during the outbreak condition. Now, the question also is how we will be moving to increase the availability of the MAP 114. That is something quite critical as we do speak now, because research has managed to provide those treatment because they were coming from the clinical trial. Now, as we scale, as we know that this outbreak will keep on continuing, it's critical to ensure that we scale the production of those treatments. Thank you.
Thank you very much, Prof. With that, we come to the end of today's briefing. I will turn it over to you, Prof, for your parting comments as we close.
Thank you so much, Nick, for stepping in, our director, Margaret, for this press briefing very nicely. Thanks for all the journalists for being there, for sending the right information, and then for once again making us accountable through your question, through your engagement, and ensuring that we keep on doing the right thing. So we'll be happy to have you next week at the same time. Thank you.